and then we'll get into the actual SIV. So if we start from our side first, so Mark, do you want to go first?
Yep, afternoon everyone. I'm Mark Edwards, Prof of Anaesthesia in Southampton. I'm acting as the CI for the UK arm of the LOLIPOP trial. Welcome.
Thank you. I'll go next. So I'm Chloe, I'm the UK trial manager based at Bristol Trial Centre at the University of Bristol. So the sponsor is University Hospital Southampton, and they've delegated sort of day-to-day trial management to us at the Bristol Trial Centre. And then I work closely with Leah.
Hiya, I'm Leah, and I'm the Deputy Coordinator on LOLIPOP, working with Chloe at the Bristol Trial Centre.
Thank you. And then we also have our administrator, Annie, who you might hear from as well, who's not here today. I'll just go around in order on my screen. So the big room, do you want to take it in turns to introduce yourselves?
Hi, I'm Natalie. I'm the facilitator for the Whittington. Hi, I'm Hamdi. I'm a research nurse.
Hi, I'm Lily. I'm the lead research nurse at the Whittington.
Hi, I'm Amy and I'm a research practitioner. Hi, my name's Alicia. I'm one of the research practitioners at the Whittington.
I'm Ghost consultant anaesthetist and I'll be the PI for the study.
Hi, I'm a consultant anaesthetist as well. I'm associate PI in the study.
Hi, I'm Imad, the senior breast fellow here at the Whittington.
Thank you. Sorry.
I'm Jess, Julian, sorry.
Pharmacy and Jess.
I'm Sana's here.
Great. Thank you. Julia. Oh, I can't hear you.
Oh, yes.
Oh, there we go. I think.
Can you hear me?
Yeah.
Yes. Hi, sorry. My name is Julia. I am a pharmacy technician at Whittington.
Thank you. Jessica.
Hi there, I'm Jess. I'm an anaesthetic trainee and I'm one of the associate PIs on this research project.
Thank you. And Sana.
Hi, I'm Sana. I'm the clinical trials formulary and I'm a pharmacist at Whittington.
Great, thank you. And I think, Amy, your laptop for sound. Is that right?
Yes,
Yeah. Great. So I'll hand it to Mark then and we shall get going.
Thanks, Chloe. So, right, this is your site initiation visit for the LOLIPOP trial. This is the acronym for long-term outcomes of lidocaine infusions for post-operative pain. Chloe's given you a bit of an intro to the setup in terms of being sponsored by my employer, Southampton, but run day-to-day by the Bristol Trial Centre. The trial originated from Australasia, and it's their brainchild, coming from the Australia and New Zealand College of Anaesthetists Clinical Trials Network, team led by Thomas Corcoran and Andrew Toner, over in Australia, and had been running in Australasia for a year or two before they reached out to the NHS to see if we would participate as well. And we managed to get some funding for that through the NIHR, with me leading the UK arm and get going for recruitment last year. The idea is that we're going to recruit hopefully at least 20% of the overall trial population from the UK. That will obviously help with trial recruitment overall, and also will bring some NHS specific data, which, as you'll see in a moment, is quite important with the slight differences in care pathway. Yeah, we're basically planning to recruit 1,000 participants in the UK, of which we've got nearly 200 already, which is great progress, for a period of recruitment for a few years. And the overall trial is hoping to get 4,300. So next slide, please. So general summary of the trial. We're looking at the effectiveness of lidocaine, IV lidocaine infusion, which is given during surgery, and in some patients is extended up to 24 hours post-op, but not in UK patients. And the idea is to see whether this reduces the incidence of moderate or severe chronic post-surgical pain a year after surgery. Okay, next slide. So the inclusion criteria are fairly broad, really, in terms of the actual surgery the participants can be having. So they just need to be adult females, and really it's any surgery for the primary excision of either a confirmed or suspected breast cancer under a GA. So that can mean either unilateral or bilateral surgery, although the vast majority so far has been unilateral, but it can include either more breast conserving operations like wide local excisions, or all the way through to mastectomies. Even things where there's a sort of simple reconstruction at the time of surgery. So tissue expanders, perforated flaps, that sort of thing can be included, but not staged major autologous reconstructive surgery. So the only other thing is to say that patients should be relatively fit in terms of the ASA, so 1 through 3, although 3 is obviously not that fit, but we certainly don't want patients with very serious comorbidity in terms of ASA4. Exclusion criteria are designed firstly to avoid any sort of confounding in terms of assessing the effects of the intervention. So if there's pre-existing chronic pain at the site of surgery, then they're excluded. If it's repeated surgery, again, where they would have had one operation without the infusion potentially, they are also excluded. And then other things are really about safety. So we're very keen that the lidocaine is tested as a safe intervention. So if there are any issues with whether it's lidocaine metabolism or susceptibility to lidocaine side effects, then they're excluded. And there's quite a whole list of those things. But the important point is that you don't need to do any additional screening in terms of blood tests or ECGs that weren't being indicated anyway to try and detect these. It's just if these things are picked up during the patient's preoperative assessment. Okay, brief pause to see if there's any queries about inclusions, exclusions, or overall trial plan. No, okay. Just put your team's hand up if you do want to stop and ask anything. It's easier to do as we go along. So this diagram from the protocol gives an overview of the trial process. You can ignore the part that talks about the post-operative infusion. We know that we're not going to run that in the UK, but essentially the green parts are the run into surgery. Trial approach and recruitment is designed to sort of allow it to match your local pathways. So for example, whether the first contact is by electric phone, whether it's through clinic and so on, and depending on what visits the patient has to your hospital in their run-up, the protocol is quite broadly written to allow it to match with your pathway. The key thing really is that the decision-making process around whether a woman wants to participate should really be completed before they attend on the day of surgery. So even if you're physically asking them to sign the consent form when they arrive on the morning, that's not really about confirming or deciding. Really it's a case of just literally signing on the dotted line because they've already decided. So usually you need at least 2 contact points with the patient before they're coming in for surgery, perhaps 1 to introduce the idea of the study and to give an outline, then to give them an opportunity to read the information, and then a follow-up contact, whether it's by phone or in person, in order to go over any existing questions and see what their answer is. What you don't really want to be doing is going into the day of surgery with uncertainty about whether they're going to participate, because it obviously makes it hard for you to plan. And if the patient feels that they're being asked to make a decision on the day of surgery, I think quite rightly that would feel a bit unfair in terms of information overload. So try and get the deciding done before they come in, but you can actually physically sign the consent on the day of surgery, or if you'd rather, you can post it out to them in advance for them to pre-sign if you trust the post, which we don't. Bits of data collection along the way, obviously. So once they have been recruited, there's some baseline data. They'll be then randomized once you've done your final eligibility checks, and that does need signing off by either the PI or somebody delegated to have that role. So eligibility gets signed off, they get randomized, and they'll be allocated a vial which is labeled as an intraoperative day case vial, basically. During surgery, importance to have research team presence, really not necessarily constantly throughout the surgical journey, but certainly at the key points. It's really important that the clinical team, anaesthetists, surgeons, recovery staff are all aware that this particular patient is going through the LOLIPOP trial, that they have an awareness of what's involved in the trial, the do's and the don'ts, and that things like there are team decisions around how much alternative local anaesthetics can be used for infiltration and blocks and so on. So really getting the research team embedded with that peri-operative team, so this is very much a sort of multidisciplinary exercise in getting them through the operation. So attendance at team brief, liaising with the anaesthetist in advance of the day of surgery, and then on the day. talking with the the scrub team, so there's clarity about how much other local anaesthetics can be given, liaising with the recovery wards, so they know how to deal with the patient, and basically making sure that you're then there and available when the patient reaches recovery, so you can be doing the lidocaine safety scoring, collecting the data, keeping an eye on the infusion, and so on. You may well get to a point in the future, once you're really experienced with the trial, where some of those bits of activity can be appropriately delegated to the clinical teams. For us, I've got to say, in Southampton, we're nearly 50 patients through, and we're still pretty much having it as a sort of handheld by the research nurses on the day of surgery. And I think that just helps to maintain a level of patient safety and compliance with the trial procedures. What I would say, though, is it's pretty low impact. We do get the odd late finish, even after a day case operation, but our research nurses love running these ones. It's all done and dusted really within the same day, and it's very satisfying because you can get usually a pretty decent number of recruits as well, so they're really happy with the sort of the turnover in the trial and the fact that it's very straightforward to run on the day. So coming back to data collection, there is some intraoperative data to collect, and then some post-operative data. We really encourage you to, although we are using paper CRFs as the primary source data, we really encourage you to upload those to the trial database as soon as possible. You may well find the most convenient way of doing that is that perhaps when the patient is going through theatre and the surgery, that you actually, you sit down at the computer, get the pre-op data uploaded. You may well find that if you're then stationed in recovery afterwards, while the patient is recovering, you can then be entering their intraoperative data, and that's done and dusted. The really important thing about that is that it'll flag up on the database. If there's any data queries, we can come back to as soon as possible. That helps the safety, helps the data, robustness for the trial as well. So really encourage early data entry from that. Once the patient's gone home, things become very straightforward for you. So any patient-reported outcomes, which includes the primary outcome, is actually done through an automated central alert that goes directly to the patient, and they then interact directly with an online database. So in theory, if your patients respond well to those reminders, you should not need to be contacting them once they've gone home. There is obviously a sort of 30-day safety check. You need to look in and just see if they've had any readmissions and other treatments, that sort of thing, just for safety reporting. But the sort of the long-term follow-up, if it's done, if the patients do well, then you shouldn't have to get involved too much. The only ones really are if there's any queries that are raised by their responses, or if the patient doesn't respond to the sort of automated requests to log in and put their information in. So yeah, didn't talk too much about the infusion itself. We can go through that in a moment, but it's pretty straightforward. As I say, none of our UK sites are actually going to be tackling the subcutaneous infusion and the overnight stays. It doesn't really seem to be something that happens in the NHS a lot. If anything, we might have a few overnight admissions more for social and logistical reasons, but certainly seems that day case breast surgery is by far the most frequent way that things are done here. So doing it that way basically keeps the trial most representative of NHS care, to be honest. Okay, let's take a quick pause. Any questions on that, on the trial overview, on the training module that you've gone through about that, or anything else so far? Floju. Oh, you're still muted. There we go.
Yeah.
Hi.
Yeah.
Hi. Okay. Sorry, anaesthetist. Just I might have missed this at the start, but in terms of recruitment, just mastectomies, white local excisions, or just mastectomies alone?
Everything. Basically,
yeah.
What
about the ones with sentinel node biopsies and auxiliary clearance?
Yes, please.
Because obviously, because those obviously a lot more painful rather than just the breast alone. The other thing is I often do I GA them, and then I'll do PECs and serratus blocks, but obviously with the 1.5 with adrenaline, that's not going to be enough volume. So what I was planning, I don't know whether you agree. Sorry, are you anaesthetist by any chance?
I am. Yeah.
Okay, cool. I was gonna, because it's a volume block, right? So I was gonna just increase the volumes if I need with saline. I mean, obviously keeping to your 1.5 with adrenaline kind of thing. Would that be okay?
Sounds perfect.
Okay.
Yeah. So you're absolutely right that the axillas definitely do have more pain. That's almost a real important reason to get them into the trial, because that's going to be a higher risk population for chronic pain. So we really need to see if the lidocaine helps them. And yes, blocks are absolutely fine, very common in the UK, as long as the overall dose, which is obviously slightly lower than it would be if they weren't in the trial, as long as the overall dose is not above the upper limit that we recommend, then yes, by all means use the volume. I do have some very keen regional colleagues who had some doubts when I presented the trial to them, but actually are really happy with the way things go. They're continuing to use their blocks at a lower dose, and they're very happy with the results so far.
And intra-op in terms of IV, sometimes I sneak in some magnesium. Should I just avoid that? Or what do you think?
I think it should be okay. Are you thinking about sort of potential cardiac side effects, that sort of thing?
No, I don't want to, because obviously magnesium's got tiny bit of energy, so it kind of
Sure,
I can avoid it. I don't.
No. Please do. Analgesia wise, we recommend you do anything that you normally would, and the rationale is that around the world there'll probably be quite a number of people who would use a bit of magnesium, and because we're randomizing so many participants, 4,000 around the world and 1,000 in the UK, what we would naturally expect is that the number of participants receiving magnesium will pretty much be the same in the intervention group and in the control group. So the effects of magnesium basically get cancelled out. So do go ahead and use your other normal practice, absolutely.
We normally do TIVA, and that's okay, right? I mean, just do the TIVA random. Okay,
yeah,
cool.
no
Thank
problem.
you.
That's okay. With the TIVA, it's just a bit of a decision about whether you would want to, if you've got a lot of things attached to one cannula, you might choose to maybe put in a second cannula just to make life a bit easier. But whatever works.
I was planning with the lidocaine I would tell patients get extra small blue cannula in their feet or something, if that's okay with your trial. Then just separate for your lidocaine.
Yeah, no,
special.
absolutely fine. Yeah, that works well. Great.
Thank you so much. Thank you.
Okay.
Do you want to say anything, Christoph?
No, I didn't have a question. Just sorry, I think Floju is probably clinical and managed to join in the middle of her theatre. She's one of our consultant anaesthetist colleagues, and she regularly does the breast list. So it's great that she could join us. Hence all these practical questions. And I think
that's what the meeting's for. It's all good.
Yeah. And I think if Floju's still on the line, I mean, I think in routine cases, you probably wouldn't have to even put another cannula, because the way we use the bi-connectors and the Siamese giving set for the TIVA, we have enough access, but obviously it depends on the case. So that's no further questions at the moment. Anyone else? Does anyone else?
Can I just ask?
Sorry.
Yeah, I just want to ask about the patients who, let's say, they come for wide local excision for breast cancer, and then they come afterwards for excision of margins. I know excision is an exclusion criteria, but obviously we're going to be subjected to another surgery. This will affect the data and the pain post-op. It's going to be following them up for 1 year, because obviously they get the excision of margins, so another surgery within sometimes 1 month to 2 months. So what shall we do concerning the outcomes for such patients?
Thanks. Yep. You're absolutely right. We'll probably end up with something like a 20% rate of margin re-excisions. It's hard to predict and it's hard to avoid. So we're not going to try and avoid it, basically. All I would say is they can only go into the trial once for the primary excision. So they must not go into the trial again for the secondary excision. The secondary excision is noted in their outcomes. At the minute in the UK, because we haven't quite sorted out all the ins and outs of safety reporting, at the minute, if they're re-hospitalized, obviously, it does get reported as an adverse event. And because they're overnight, it ends up being an SAE we all know that it's actually though an expected thing. So we're currently going through a protocol redraft for the UK, just to make it clear that this is an expected occurrence within the trial, and to make the reporting of it a little bit less cumbersome. But yeah, we're expecting it. Like with Floju's point about, you know, magnesium, we would expect that we'll end up with equal numbers of re-excisions for margin in both groups. So yes, it does put a different spin on what's happened to their long-term pain. All I would say is probably they're a group that's at slightly higher risk of chronic pain afterwards. And so again, you could argue that makes it even more important to get these patients in the trial. And I know that for that second surgery, you know, they wouldn't have the benefit of the drug potentially. So it might reduce the effect of the intervention overall, but you know, it's so hard to avoid and so hard to predict that there's nothing you can really do to avoid that completely.
But they'll be randomized anyway, so
they would have been randomized for the index operation. Yeah.
Yes, they should be equally on both sides.
So then,
Exactly, yeah,
So
yeah.
just to confirm what you were saying, any secondary surgeries that you need, we document as an AE at the moment.
But SAE, it sounds like.
Yeah, assuming, although we're only collecting SAEs up to 30 days.
Okay.
I mean, most of these re-excisions probably will come through quite quickly. So yes, we are having a few reported at the moment.
Okay.
I'd just say don't worry too much. We know that it's happening. It's not a big thing. It's a bit of a quirk of the safety reporting system in the UK, and we're tweaking things just to make it a bit less onerous, basically.
Thank you.
Just one last very quick question that I probably know the answer to anyway. In terms of the eligibility CRF, obviously we are going to know at least a week in advance of patient surgery whether they're eligible. Just wanted to check that that could actually be signed off kind of a week or 2 weeks in advance of the surgery.
Yeah, I mean, the only thing I'd say is that you just need to do a final check on the day, because if they suddenly started, if they went to the GPs 2 days beforehand for their blood pressure and got put in a beta blocker, by the time you're seeing them in surgery, they wouldn't be eligible anymore. So I guess for eligibility, we often do it at Southampton such that the team will screen, they'll send around a list for PI and API to have a look at. Whoever's got time logs in, has a look at their details and says yes. Basically, so there's an email trail to say yes, we think they're eligible. We tend to actually sign the form pretty close to the day of surgery, so that they've definitely been through pre-assessment. You know, if they're going to have bloods, they've had their bloods done, ditto ECG. So by the time we're actually putting pen to paper on the eligibility form, you know, we're 99.9% sure they truly are eligible, and it's really just that final check on the day of surgery to make sure they haven't had any new medications or new changes since like 2 days ago, basically. So yeah, and you might want to, you know, I'm sure you'll find a way of working that so that, you know, it's kind of, you've got a valid form confirming eligibility. But yeah, a lot of this stuff can be done in advance.
Another quick question about eligibility. At other sites, is it typically the surgeons or the anaesthetists who are confirming eligibility, or is it kind of a 50-50 mix?
Honestly, I'd say probably mostly anaesthetists. I think we do have some surgical PIs, but honestly, it tends to fall to the PI and then APIs pitching in if they're involved as well, who can obviously come from any specialty. I know our second lead site, Bristol, they did try and start with a kind of a surgeon-initiated model of identifying patients, and to be honest, things went a bit slow. So they kind of brought it back to, you know, research team with anaesthetist support for kind of doing the whole patient finding and confirming. Surgeons are super useful to promote the trial though. So if they're seeing a patient in clinic and they can say to them, even without, you know, being on the delegation log, they can say to them, by the way, we're doing a really important trial. There's the poster out there. Have a look at it. The team might be in touch with you. That is really useful, because if the patients think that the surgeons are really promoting it and encouraging them to go into it, that is really sort of powerful for them agreeing to participate, which is a bit irritating for anaesthetists that they so much power there. Yeah, get involved, but I would say it's mostly anaesthetist driven.
Okay, interesting. Thank you. And then, sorry, just another one following up from that. When you have the anaesthetist confirming eligibility, is it then typically falling on the research team to consent, or again? Okay, cool. Thank you.
Yeah, we've got essentially like we have our research team in kind of, they're like the proactive, leading it, steering it, doing the contact, getting the consent, and we're there as sort of responsive, helpful, trained people who can say, yeah, that looks good.
Perfect. Thank you so much.
Thank you. I think that's all of our questions for now.
Cool. Let us move on.
Thanks, Mark. Just over to me for a couple of slides. I'll admit here I forgot to ask the Australian team for an overall trial. So I haven't got those numbers for you, but I can give you an update on how we're doing in the UK. So yeah, as Mark mentioned, we're nearing 200 participants. I think as of this morning we had 186. We have got our end of pilot review with the funder at the end of this month, so we're keen to try and get to 200 if we can, but everything's sort of looking positive for the trial progressing. So yeah, all looking good on that front. And then, so yeah, this, I forgot to say at the start as well, sorry, that the SIV is based on the assumption that you've kind of watched the training videos. So we wanted this to be more interactive rather than us just talking at you. So slides like this is, we're going to talk through some processes at your site, and this is on the assumption you've watched the training videos, but if there is anything you want to ask that we don't cover, please do just, yeah, raise your hand or shout out. But yeah, so just to think about processes at your site then, have you thought about who will be sort of identifying patients and approaching? We did just, I think, touch on that, but has that given you sort of any thought on how you'll run things at Whittington?
For the most part, I think it'll probably be the research team identifying the patients. We've kind of, our surgeries typically happen on a Thursday, and every Thursday we've kind of been keeping up to date with the theatre list to see who would be eligible that week and kind of plan ahead for us to know how many numbers. We were then thinking, again, after the SIV, I think it would be useful if we all kind of speak with the surgeons as well, to see who would approach and potentially likely approach while they're in the surgery clinic. I don't know what your thoughts are with that.
Yeah, I mean, usually the consultants see the patients in the treatment clinics and they discuss the patient for surgery. So I think that could be an entry point where they get notified about the trial. You know, this is if I know about it. If you're happy to join, then yeah, absolutely. And that's typically like at least there's like a big chunk of time before the actual surgery. Yeah, like for now, for example, we have all the lists booked until end of November. So they know they have surgery in this day. So they will have much time to know about the trial and decide before they have the surgery dates.
I think whether we give them the PIS and get the eligibility kind of confirmed before that or after that, we can work out. Yeah.
Great, thank you. All sounds good there. Have you thought about sort of your plan for the day? Obviously, day of surgery is quite a busy time, and we state in the protocol that randomization has to happen on the day of surgery. So obviously that adds sort of another complexity to an already busy time. Have you thought about that? Do you know if you'll be storing IMP in pharmacy or in sort of a cupboard near or in theatres?
I think our plan is to store it in pharmacy, which would be fine. And Costas is obviously our PI for this study. We've just stopped working on a previous study that was quite similar in terms of approaching the patient in the morning, randomising on the day, and talking to the anaesthetist involved. So it's quite similar to kind of what we're used to. So I think it would be running kind of okay.
I think in terms of the randomization and the final sort of confirmation of eligibility, compared especially to the previous study that was similar, we have more stability in who covers these lists and from attending anaesthetist point of view. And also Brian as an API and myself are working clinically on Thursday. And Thursday has a bit of a later start because of educational meetings of various teams. So that just gives us the flexibility to have the appropriate cover and the time to randomize, bring the infusion set up, do all like checks, etc.
Great, sounds good. Thank you. I think because you said you run a similar trial, but just something we usually say to consider when IMP is being stored in pharmacy is obviously I don't know if your pharmacy has sort of opening hours and if the first patient on the list, you know, whether you would be able to randomised and go and collect the vial before if the patient's first on the list, or whether you will avoid lollipop patients being first on the list.
We thought because of the teaching and so on, like you guys start at 9, right?
Yeah, so we generally we start at 9. We have an hour of teaching in the morning, which we might not always be available. But from 10 o'clock onwards, as usually, we'd make sure that there's always 2 people on site. So I assume it's a same day dispensing that we're talking about, right?
Yeah.
So
but we would need it like before 10, definitely.
Yeah.
After 9, but before 10. Would someone be available for that?
Yeah, we can make someone can be available. Yeah, that's fine.
Where have we got to? So yeah, not something to probably think about initially, like get yourself familiar with the trial to begin with. But once you're sort of running and familiar, have you thought about the potential of having 2 lollipop participants on the same theatre list at all, and logistically how that might work?
Not in the first instance, until we're kind of, for the first chunk of time, until we're like up and running and confident with how it runs here.
Yeah.
I don't think, yeah.
We need a second pump as well.
Yeah, you've only been given 1 pump. If we do okay with the first pump, maybe
with the second pump.
So yeah, so that was one thing. Well, something we discuss in SIV is definitely when you're getting familiar, just one, get yourselves familiar. Once you feel comfortable, if you did want to start looking at having 2 on the same list, there might be a possibility to explore a second pump, but that is sort of dependent on funding and how well you are recruiting. The other options we kind of give is if you have any stay over theatre lists, perhaps put in a non-lollipop patient in between 2 lollipops, or once the participant is going into recovery and they're on the mils per hour infusion rate, you can switch the mils per hour to a sort of standard clinical pump, which will then free up the actual lollipop pump for the next patient as well. So obviously, yeah, if and when you're ready to do 2 on the same list, we can talk about that more, but definitely just get yourselves familiar with the trial to begin with.
I think it's definitely something that we thought about. Also, one more reason being that at times, I don't know how regularly, but sometimes there are 2 breast lists running concurrently on the same day. So, we need to be open to the option of having to do 2 in a day, or even 2 simultaneously potentially.
Yeah, okay. So yeah, next one was just checking that all sort of teams involved are aware of the trial. Have they sort of had any training materials? Have you had any discussions with them? I think we got representation from most departments here today. But yeah, how have sort of conversations gone with your colleagues? Are there any sort of concerns or anything they wanted to raise? Or have you not sort of had those in-depth conversations yet?
We'll just speak
We
about the
thought
recovery.
it's not very nice to do, just to make sure that they're happy so they don't get scared.
Not ready, you mean?
No, I don't think we
No.
have, so we need to do that.
So I think the issue we find invariably with these trials is when we first start out, if we go out and give a lot of information, talk to people, when eventually we do get around to starting it, everyone denies all knowledge.
Yes.
Because they've forgotten. So I think, following on from the SIV will be the time to really get that information. The anaesthetic department has known for a little while, and they're happy, but it's some at the theatre level, the various staff groups at theatre level that we will sort of speak to, I think, over the following.
We spoke to ODPs yesterday, and we can go and we'll go and speak at their teaching on a Thursday morning as well, once the trial's open, and we'll do the same with anaesthetics and recovery.
Perfect. Yeah.
Great. Just on that point, we do have 2 slide sets that we can send over to you to help with, if you're having those discussions with. So we've got one for recovery staff, and then one for anaesthetists who, in Lollipop, I think we cover it a bit later in the slides, but in Lollipop, if anaesthetist is just the attending anaesthetist on a Lollipop case, and that's sort of all their level of involvement in the trial, they don't need to be on the delegation log, they just need to complete a simple slide set of training. But if they are going to be more involved, signing off eligibility, things like that, they do need to complete sort of more in-depth training and be on the delegation log. Was that a question?
Yeah, so when it says interoperatively, then if you've got an attending anaesthetist that's not on the delegation log, that's only doing the interoperative infusion, in terms of like I'm sure you're going to cover this, but I was thinking like in terms of like signing off for that PRF, there would have to be a delegated member of the research team.
There has to be two.
Yes.
There'll be two delegated members plus the anaesthetist, would it be? Or...
So if it was an attending,
That'd be one research.
So
anaesthetist.
Yeah.
Yeah, so how it's worded is actually, so it's a minimum of 2, so you definitely need 2, but as long as there's one delegated member, the second one can be sort of the attending anaesthetist.
Okay, that was my question, like one delegated and yeah, okay. Yeah. Thank you.
Great, and then the final point is just, have you had chance to look at the staging database, which is sort of a test mock database, and do you have any questions about using that?
I haven't had a chance yet, sorry.
That's all right.
I've had a brief review of it. I think it's quite clear, to be honest. I think we're quite familiar with ranges of database, but it seems like quite a clear one. I didn't really see anything that I had to flag up as anything. Yeah. Just a question, and maybe it's because I've not thoroughly looked at the database, but obviously we have the main database, and then we have Mango for delegation log and CVs, GCPs, and then we have REDCap. So obviously REDCap is used for follow-up, is that right? And for kind of mortality checks, is that right?
Yeah, so Leah will come on to that a little bit later, but yeah, essentially the REDCap database is purely for anything patient reported. So that's the reason you do the mortality checks on there, and then the questionnaires will just get sent to the patient and they fill them in. Any sort of data you're collecting, so medical notes, intraoperatively, things like that, that goes onto the sort of main trial database.
Perfect, thank you.
So, yeah, this in a little bit more depth in a few slides. So. Great, I'm going to hand back to Mark for a couple of slides now. Or was there any other questions, sorry, on screening, consenting or randomizing?
Sorry, can I ask just something from the pharmacy point of view?
Yeah.
Regarding the delegation, accountability logs and training logs, we can keep our own, like in-house logs?
So we say we would want sort of the lead or whoever's going to be sort of the main contact for Lollipop. We say we want them on our training log and
the main
Mango, but we're happy for you to sort of keep your own logs for everyone else. But we would just want a file note to document that in your ISF.
Do they need to be approved? Or
I don't think so, no.
Okay.
I'll double check that one and I'll confirm in an email if that's
Perfect.
okay. But I think we're happy to leave that.
And
as long
also,
as we have the main person.
Brilliant. And also we were debating about if we should have our own prescription template. Obviously database is different, so it's just, so we decided that we will keep our own prescription. And I think as far as I remember, you said that it doesn't have to be approved. Is that correct?
Yeah.
Okay. Okay, brilliant. Thank you.
Great, thank you. Over to you, Mark.
Great stuff. So just to highlight for a few minutes the role of the dispensing sheet, which is a really useful and key part of the trial intervention on the day. This gets generated once you have randomized a patient. So you can see in this example here, it's got the participant number, and it's got the calculations that it's made. So as part of the randomization, you program in the patient's height and weight and so on, and it will do a calculation to give you a lean body weight. And that's the basis for the infusion dosing. And you can see it's done all the maths for you there. And that is the basis of the cross-check against the pump that you'll do after you've programmed the Alaris pump before handing it over to the anaesthetist. You can see at the bottom with the red things, that's what we were sort of talking about earlier. So it's the 2-person check firstly of the vial itself. So that's the main thing, and then the second thing is then to cross-check with the anaesthetist about those numbers. So cross-checking against the pump to make sure that the numbers that you've got there relate to what the pump has also calculated as well. Yellow box there highlights that we've discovered there's just a very minor, I think, rounding difference between the calculations that the database does and the calculations that the pump does. If you do find that there's a 0.1 mil per hour discrepancy, that is acceptable. I'm sure if you work out the maths of what that means, it essentially means that the infusion might be running for 1 or 2 seconds shorter or longer than what the database says. So it's clinically completely insignificant. It's just a slight maths differentiation. So yeah, if you notice a small difference of 0.1, that's absolutely fine. Any big differences probably point to the fact there's been some incorrect entry maybe of the patient's weight into the pump. So that's the reason for cross-checking. The other point there that's really useful and an important part of the day, we've talked about a little bit already, is the blue highlighted bit. So this talks about other local anaesthetics that are permitted, whether it's for the sort of blocks that we've heard about or whether it's for surgical infiltration. That's actually based on their raw body weight, but essentially it gives a dose that is allowed. Now, obviously, depending on the familiarity with milligram dosage, people will sometimes need that converted into how many mils of various different strengths of solution there are. We can provide you with, or will provide you with, a little Excel spreadsheet that you can have on an iPad or on your phone, and you basically, it'll give you the numbers in terms of if they want to use 0.25 bupivacaine or 0.125 or whatever else. It will tell you how many milliliters that relates to for that particular drug. Okay, any questions? Yes, Jessica.
Just to double check that I have understood that correctly, the blue box referring to the maximum dose, this is referring to the maximum dose that we can administer given that the patient has already had the lidocaine that we're administering. Is that correct? Not the total maximum dose. This is the maximum dose minus the lidocaine fraction.
Correct, yeah. It's not done on a sort of total 50-50 way as others have advised, but it is something that they've been using in the trial consistently. They had a pilot trial of a couple of hundred participants. We've had over 1,000 participants in LOLIPOP internationally now. We don't actually think there's been a confirmed case of local anaesthetic toxicity in all of these participants. So it seems to be working well. They did quite a lot of stuff looking at lidocaine levels and so on in the first pilot study as well. So they've got quite a lot of data on this. And yeah, it's in addition to whatever the study will be giving them.
Fantastic, thank you.
But just to say, obviously, it's only one of those. You can't give bupivacaine without adrenaline and bupivacaine with adrenaline and ropivacaine. It's choose your one, and that's
that would be quite the cocktail. Agreed.
That would be pretty amazing. But just felt I need to say it anyway. Funny things happen. Cool. Okay, next slide, please.
Has it not changed?
No, not for me anyway. Has it changed for anyone else?
No.
It's changed for me.
Okay. I can see the next bit.
Yeah, it just changed. I've got a delayed connection, obviously. So just talking through the actual pump itself, you'll see in some of the older Australian training materials, they're still using the Alaris PK. All our UK sites will be given the newer pump now, which is the Alaris Nexus PK. They're very, very, very similar to the previous ones. You just have to pause during the setup at a slightly different point. But we've done a video on this. So in the infusion setup training thing, there's the original Australian one, and then we've put on a little bit just to explain how things work for the newer pumps. But basically, it's very simple. You turn it on, you choose the lock setting. Obviously, they've been programmed. You cannot give like propofol anesthetic through these things. You can't give a remifentanil anesthetic through these things. They've had those programs removed. So the two options are either to give something in milliliters per hour as a sort of very simple infusion pump, or to use the LOLIPOP program. Those are the only two things available. So you obviously select LOLIPOP, you put in the lean body weight, and we've put stickers on all of these just to remind you that it is lean body weight, not actual body weight. And then it'll essentially give you a screen that confirms the doses that you can see on the dispensing sheet. And what you need to do is just pause there. Don't set it up any further. Hold it there. It won't alarm. And then just wait until the anaesthetist is ready to cross-check it with you. And so you just go through what's the lean body weight, what's the concentration, what's the intraoperative bolus, what's the bolus rate, what's the intraoperative infusion rate. Just cross-check with a little signature in all those boxes on the dispensing sheet. Once that looks okay, you press OK on the pump, and the pump will just be on hold waiting for the anaesthetist to start it once they've connected it up, and they're happy to start it after they've got the patient to sleep and secured the airway and so on. So straightforward. All the setup is done. So all the programming of the pumps is done by our medical engineering team in Southampton after they've received the BD pumps, and they'll ship them out to you. Your local engineering team will probably just want to do at least pattern testing and all that sort of thing, but they don't need to do complex calibration tests or maintenance schedules or anything for these things. They've got a 3-year maintenance schedule, so if we all recruit well, these might not actually need scheduled maintenance while they're being used in the trial, all being well. We've got some spare pumps. If in the they're very robust, but in the unlikely event that you have a malfunction, we can swap you one in and send it back to us. And I guess the other thing to say is, oh no, we'll talk about this later. We're talking about having 2 cases and multiple pumps and what to do. But yeah, they're pretty straightforward. Do you tend to use Alaris for your TIVA?
So, yeah, Mark, we have Alaris, not the Nexus, just BK.
Yeah.
I'm assuming you sent us the Nexus, correct? Yeah. Okay.
Yeah. A little tip.
It's pad tested, it's done. Yeah, pump's ready to go.
Sure. Obviously, we do plaster it with stickers to make sure that nobody gets confused with using it clinically. All I'd say is if you're using 3 of a similar type of pump in theatre, it's quite useful to separate this one physically, just if everything's kicking off and you want to suddenly deepen the anaesthetic. You don't want to accidentally reach for the lidocaine pump instead of the propofol pump. Unlikely, but you want to make everything as easy as possible to do the right thing. So you might want to have it on separated on the drip stand, or maybe on a different drip stand. Whatever you think would work, but just be aware that all the buttons on them look the same. So just be mindful of that, and perhaps just think about physical distancing from your anaesthetic pumps.
Definitely a good point. Although it does look physically slightly different, like it does have a different color.
Yeah, that definitely helps. Yeah, that definitely helps. Slightly different color.
What you suggested is even more robust. I have one little quick question based on the. Are you going to say more about the pump though?
I might do. No, go for it. Fire away. We can.
Don't want to steal your thunder then. No, go on.
No, go on.
No. In the video, it just said about the failure to deliver the bolus.
Oh yeah, we've got a question on that. That's cool. You can tell us the answer to that in a minute. Yeah.
All right, so testing it.
Yeah. All right, next slide.
Okay, go on then. Yeah.
It's back to me. Thanks, Mark. So yeah, just going to run through a few safety aspects of the trial now. Yeah, this is quite a whistle-stop tour, obviously based that on the assumption you've watched the video, so please do interrupt me if you want any more information on anything. But the table you can see on the screen now, I'm not sure if Annie sent your startup pack yet, but if she hasn't already sent you this, she will be. So we recommend keeping a printed copy of this with the patient at all times whilst the study infusion's running. There is also a copy within the protocol, and it basically just sort of details the instances when you should stop the infusion. So sort of identifying safety concerns early, basically. So yeah, to keep a printed copy with the patient at all times. So for example, even when if it's just an attending anaesthetist, not say a LOLIPOP fully trained anaesthetist, to know when the infusion should be stopped. Moving on to the lidocaine infusion surveillance tool, or we sort of refer to this as the list tool. So this is a So the Oz team designed this tool, and it's designed as a rapid aid to identify clinical signs and symptoms of potential sort of early signs of lidocaine toxicity, and sort of this would also lead to the IV infusion being stopped. So there's 5 symptom questions and 7 clinical signs assessed using this tool. So for day case participants, this is completed twice within the recovery area. So you should complete the tool once within 15 minutes of the participant arriving to recovery, or sort of when they're awake enough to have a conversation. And then again, when they sort of meet the criteria to leave recovery. If at any time the participant answers yes to 2 or more symptom questions, or they have any signs or complications at any time, you should stop the infusion. After stopping the infusion, if the patient is sort of otherwise well and stable, you should sort of just repeat the list tool hourly to monitor, and continue to do this until symptoms have resolved or 2 hours have elapsed, whichever comes first. If sort of all fine, no need to do anything else. That's sort of that. If the patient is unstable or sort of gets worse, this is when sort of there's a bit of a concern, and you should initiate, so however it works at your site, so rapid or urgent review by the anaesthetist or theatre emergency team, critical care team, however sort of that works logistically at your site, and tell them that the patient is a LOLIPOP patient and has the possibility of lidocaine toxicity. If there's suspected severe lidocaine toxicity, then you should follow the AA GBI guidelines and unblind. I think all sites have the quick reference handbook as well. So if that's sort of closer to you than AA GBI guidelines that we provide, obviously use that, whatever in that emergency situation is closest. If intralipid is indicated, so for example, circulatory arrest, don't wait for the unblinding result, start giving that, and then you can always stop if it's the patient isn't in the lidocaine arm. And then all suspected lidocaine toxicity events are reported on our suspected lidocaine toxicity form 13, and these need to be reported to us within 24 hours, please. So as Mark mentioned, with the data entry being done sort of quite not live, but quite soon after things happen, and so that the list tool is one thing, how like we can identify sort of any issues going on as well, but we do have that separate suspected lidocaine toxicity form also. So is there any questions about the list tool, Laura?
Yeah. Who usually fills out this form?
So in the first instance, we say research team, especially while you're getting sort of familiar with the trial. But once sort of everyone is familiar, we are happy for recovery nurses to then take that over. But that would be on the assumption that the research team are sort of close by and available if needed. But definitely to begin with, we suggest research team.
And just to check, because Amy and I are research practitioners, is this something that should be done by a nurse ideally?
Ideally, but I think we've asked this question before, and it was sort of at the PI's discretion. So if they were happy for that to be delegated, but I do think ideally nurses if possible.
Perfect, thank you.
At the moment that there was any kind of suspicion of toxicity or anything anyway, it would be completed probably by a clinician, not the research team anyway, wouldn't it? I think.
Well, you can quickly escalate to
Yeah, exactly. Yeah. Okay, thank you.
No problem. And then unblinding, so sort of life-threatening events where unblinding is required include sudden unexplained loss of consciousness, tonic-clonic seizure, life-threatening arrhythmia or cardiovascular collapse. After randomization, you have the ability to unblind on the database for 36 hours. So it's quite important that if for any reason the participant's surgery date changes, you make sure you change that within the database as well, so that obviously the ability to run unblind is still available in that 36 hours after the new surgery date. anyone with a login to the database can unblind sort of through logging in through their account and finding that participant on your list of randomizations. But also we have a printed unblinding guideline. So this sort of details when to unblind, and you can see the QR code on that unblinding sheet. That will take you to a sort of generic login. So what will happen when you get access to the live databases, it's usually whoever sort of is going to be the lead research nurse will be sent 2 logins, so one personal login and one generic login. For the generic login, obviously keep a generic password, because that will then be written on this unblinding guideline. So anybody who scans that QR code, whether they are on the Lollipop delegation or not, or have an account on the database or not, can unblind. Obviously recognising that in an emergency situation, it needs to be done quickly and may not have time to wait for a member of the research team to be nearby. But also, if you have an account on the database, it doesn't mean that you need to use your account to unblind. So if the quickest way is to scan that code and log in the generic login, please do that. And then if you do unblind, we have an unblinding form within the CRF, which is CRF form 11, that would need to be completed, and also the suspected lidocaine toxicity form 13. So is there any questions on unblinding?
So am I right in assuming that if the surgery date after cancellation is not changed, then if a week later the patient is in recovery and needs urgent unblinding, even by this second route where anyone can do it, it still won't happen?
Yeah, so we haven't had a situation of that, and the Australian team built the database, but that's the sort of feedback they've given us. So I would assume yes. I haven't sort of personally come across it being tested, but yes, it's quite important that that surgery date is changed. Any other questions? So some safety endpoints. So there are some safety endpoints listed in the protocol. These overlap quite a lot with that table I showed you a few slides ago about stopping the infusion. But so yeah, just to reiterate, the infusion should be stopped if any of these events arouse cause for concern or cannot be resolved following treatment. So a lot of the events on this list are considered expected reactions and don't require expedited reporting to the study sponsor on an SAE form, but they do require an AE form to be completed. But this is with exceptions, because obviously some of those on the list, if you look carefully, are quite significant safety events. But yeah, there's lots of guidance to help you with that if and when these events sort of come about. And then a little, sorry, yeah.
Just back to the safety and endpoint. Does this mean a patient having induction and needing a little bit of ephedrine to treat hypotension after induction will have to have an A form?
No, because that's, well, Mark, do you want to come in? Resolved with treatment, is it?
Yeah, exactly. Anything that's resolved with standard first line treatment like that is not viewed as an AE. Have we got the Chloe? Have we got the CRF? I don't want to confuse matters. Basically, there's actually quite a good level of detail in the CRF. The full version of the CRF has sort of interspersed data collection thing with like guidance notes, and so it goes into quite nice depth about the intraoperative events and what standard treatments are likely to be given. It's really only looking for things that are out of the ordinary in terms of first line treatments not working.
Yes, so on there, I think you're prompted if there's, say, like hypertension not resolved with treatment, it then prompts you to fill in the lidocaine toxicity form on there, if I remember rightly.
Yeah, it gives some examples of sort of what sort of level of treatment might be reasonable.
Yeah, I'm just looking at it here in front of us. That's fine. Thanks.
And if so, again, by putting that data in a fairly timely manner, we'll pick up on if you do report something that should be reported as well. So, yeah, just highlighting again the importance of putting that data in. Is there anything else, or is that okay to move on? So protocol breaches. So there is a form within the CRS form 10 that needs to be completed for protocol breaches and entered onto the Lollipop database. UK sites, unfortunately, there is a second form. This is a paper form that should be completed and emailed to us. This is a sponsor requirement form and should be emailed to the 2 email addresses you can see on the screen there. Again, we'll prompt you if you complete one and forget to do the other, we'll prompt you. But the main reason for that is in Australia, there's a certain list, which are pretty much the ones on the screen there. They're the only protocol breaches that sort of count for them in Australia, whereas here in the UK, any deviation from the protocol is a protocol deviation. So hence the sponsor wanting the paper form completed. Just with those examples on the screen, so just a couple to pick up on. So the open label administration of lidocaine in excess of permitted amounts. Basically, if that's sort of picked up before the lollipop infusion begins, we say to not start the lollipop infusion, because obviously we don't know if that patient's going to receive more lidocaine. And if it's noticed while the infusion is being given, you should then stop the infusion, again, for the same reason. We don't know if the patient's then having lidocaine and at risk of having too much. I think that's all for that. So are there any questions on protocol breaches? Oh, great. And then, yeah, just as a brief summary for safety reporting and the forms that need to be completed. So the summary of medicinal product characteristics, or the SMPC, is the reference safety information for the trial, and sort of has the listed expected reactions in there. And then, yeah, I won't run through this table because you can refer back to it. And I mentioned there's plenty of guidance to help you along the way, but the different forms that need to be completed for each event can be seen on the screen here. But just to say, if it's anything sort of serious adverse event, reaction, SUSAR, etc., we do need to be notified within 24 hours, please. So that's either 24 hours of you becoming aware of the event, or 24 hours of the event happening. So, for example, if it's a suspected lidocaine toxicity, we would sort of expect you to be there and aware of that happening. So expect that to be reported to us within 24 hours. Any other questions on anything safety reporting wise? Great. So just a little note on intraoperative data collection. So this is a bit of a quick, with it being an international trial, different sort of dexamethasone doses, etc., used between Australia and the UK. So in the UK, in Australia, dexamethasone phosphate is used, and in the UK, dexamethasone sodium phosphate is used. And there's sort of dosing discrepancies between those two. So again, this is probably going to sound confusing as I'm reading it out, and we will prompt you if it's put in wrongly into the database. But if 3.3 milligrams of dexamethasone sodium phosphate is used, we ask that the database as 4 milligrams of dexamethasone phosphate, and similarly 6.6 milligrams of dexamethasone sodium phosphate we ask is documented as 8 milligrams of dexamethasone phosphate. But yeah, as I mentioned, don't worry if you put that in wrongly, it will generate a query and you'll be asked to update that. And we do have various manuals, so the CRF manual is quite helpful to perhaps have by your side as you're going through the first few patients to familiarise yourself in completing those. I'm going to hand over to Leah now.
Hello, so I will start by summarising the follow-up time points in Lollipop. So we have 3 follow-ups. at 3 months, 6 months, and 12 months. 12 months is the primary outcome, and all of these time points involved a patient-reported questionnaire. We're collecting that on REDCap, so most patients just have that emailed out to them, and then they can click a link and really easily complete that themselves. So with kind of minimal intervention from the research team. But if patients don't want to complete it this way, then they can request to do it over the phone with the research team. So that's an option. And also we just ask that you're kind of monitoring completion of the questionnaires at your site so that you can chase any stragglers up. There's also at 2 of the time points a bit of data collection from the medical notes. So we've put it into this table here just to kind of remind you that the data collection from the medical notes is actually collected on the main trial database, whereas all the patient-reported stuff is collected on REDCap. So it's quite important to remember if you're completing the questionnaire on behalf of the patient, like with them on the phone, that any patient-reported data actually needs to be entered on REDCap, not the main trial database. That's just because we're sort of completing some uploads from REDCap to the main database, so we don't want you guys to do any kind of double data entry or anything like that. If you're not sure kind of which data needs entering where, again, as Chloe was saying, you can refer to that CRF manual for your first few patients, and that should give you all the information you need. And then just a note to say that because the 12-month follow-up is our primary outcome, if the 3 and or 6-month follow-ups are missed, we do ask that you still try to collect that 12-month follow-up. Are there any questions on that? Okay, next slide then, please. So just to note as well, during the 3 and 12-month follow-up questionnaires, participants are asked to calculate their total daily dose of pain relief medication. To support this, we've written a guidance document that will help them to calculate that. So any participants completing the questionnaires themselves online, they will actually just be a link to this document themselves. That's really easy for you. But if you're collecting any questionnaires over the phone, we do recommend that you post a paper copy out or email a copy of this document to the patient ahead of them completing their questionnaire, but also after you've completed the mortality check. Yeah, next slide, please. So just again, we've got a few more discussion points like we did earlier. So would anyone like to comment on what you would do if participants were randomized on the day of surgery and the surgery had to be postponed after that?
So what we would do? What would we do?
So what would the process be? If you don't know, it's fine. We can run through it again. But yeah.
Did it say that we would still like? Oh, did you say so?
I think that changed the day of surgery, isn't it?
Yes.
There'll be a problem with the unblinding.
Is that correct?
Yeah, so that's important to change the date of surgery on the database. That's right. It's also just good to reaffirm the consent, just verbally as well.
Would we also need?
Right. Sorry.
Would we also need to potentially return vials to pharmacy if we got as far as getting a file out, bringing it to the anaesthetic room, and then it gets cancelled on some other grounds that means that we have to return it? What would the protocol be for that?
Yeah, so as long as the vial hasn't been opened up and loaded into the pump, then that can still be reused when they come in later for their surgery. So yeah, that would then have to be returned to pharmacy for storage, and then it could just be used when they come in again.
Yeah. So just to confirm, no one would be re-randomised if their surgery was delayed. No. You'd get the same vial. Yeah, unless it had been
exactly
someone very keen had tried to open it and get the infusion kind of going early.
Yeah, so if the vial had already been loaded into the pump, then unfortunately that participant would no longer be able to continue in the trial because we wouldn't be able to randomize them again. And we don't have a kind of spare vial system, unfortunately.
Okay. I doubt anyone's going to be that eager and keen, or they're really like very last minute cancellations. But if it does happen, then they can't. Yeah, stranger things have happened. True. Okay, that's good to know. And then they're out of the trial at that point if they can't be re-randomized under any circumstances. Okay.
Yeah, just to give a bit of background to that, it's obviously in an ideal world we'd have spare vials for just this occasion, but there's been a big logistical operation because this stuff basically originates in Australia and has to get shipped, and that brings a load of expense and so on. And essentially, anytime you have a box of something that's labelled differently from the other box, they add thousands of pounds on because they see it as a totally new product to check and import and so on. So things that said spare vials just in case added huge quantities of money and logistics to the thing. So for those very small numbers where this might happen, the central team thought, actually, let's not. So yeah, I think the only thing to say is if the list is running really late, if there's a bit of like, oh, won't we be able to get that last case done? Just hold off on cracking open that vial until you're pretty certain the patient's going ahead. But honestly, most of these cases get done, they go ahead, people run late a bit because it's cancer surgery, so people are a bit more tolerant of running on. But yeah, if there's any hint of doubt, just wait.
Just to add on that, if the surgery was rescheduled for more than 30 days after the original one, we do ask you to get written consent and recollect the intraoperative data. Baseline data, sorry.
Yes, that's right. Thank you. So the next question is just about what the protocol is if a participant has a seizure in the recovery area.
Call for help. Stop the pump, ABC. Give the
Grab the toxins.
Yeah, get the intralipid close.
Yep. Yeah, so administering intralipid, unblinding as well, and following the correct procedure that results from that result. Stopping the infusion. I couldn't tell if you said that. Sorry, I think you said stop the infusion, but it was a little bit hazy. That would be the first thing you do, and then obviously completing all the paperwork relevant to that afterwards once the patient's stable. So that would be a suspected lidocaine toxicity form, unblinding form. Okay, any further comments or questions on that one?
We just need to work out our local processes of where's best to keep the QR code and who's going to keep it and things like that. But we've worked.
Unblinding, I think the suggestion is it stays with the patient on the
So usually, I think most sites have a sort of pack or a box or something that they'll have with every lollipop patient, and that'll have the unblinding guideline in it, a CRF pack, things like that. Yeah, any stickers you need, that sort of thing.
Sorry, I forgot to mention, we do have an anaesthetist cheat sheet as well. So like in that pack is so for those anaesthetists who aren't on the delegation log, there is sort of an anaesthetist cheat sheet. Well, can also be used by anaesthetists on the delegation log, but they should know most of what's on there anyway.
We like a cheat sheet.
Yeah, nice and easy. Fab. And then it is unlikely, but what would the process be if the pump failed during the bolus infusion?
Mark's back on the camera just to answer this one. Yeah. So I heard about that because in the video it suggests that you just turn off the pump and then turn it on again, but then the next time when you turn on again, select the mils per hour and start at the suggested mils per hour for the intraoperative infusion. But I was just wondering, why do you just not like troubleshoot and then just start again to complete the bolus infusion?
Yeah, I mean, I think in reality, that was put in there to account for the very unlikely possibility that the pump just completely cuts out and fails. I don't know, maybe it's just on really low charge and suddenly the battery just goes. If an occlusion, so part of the program is actually set quite a high occlusion alarm, so it shouldn't occlude alarm that much. But if you get a simple occlusion alarm and it's a case of flush the cannula, unkink the line, whatever, oh, whoops, we had it clamped. Yeah, you can carry on. Okay, so simple occlusion alarm. It's basically making sure the pump knows how much it's given. So if the pump is still working to the program and it knows how much it's given, yeah, you can carry on. I think that's put in basically for the unlikely event that the pump cuts out in such a way that if you restarted it with the bolus, it would not know that it had given part of the bolus already, to avoid giving a bolus overdose, basically. And if that was to happen, if it totally blanked out, yeah, you do exactly what you say, restart it, but just cut your losses and go on to the mils per hour steady state infusion, and you can read that out from the dispensing sheet and just put that manually into the mils per hour rate.
Perfect, thank you.
Thanks. And then just a final, hopefully easy question. What would your process be locally if a participant wasn't responding to their 1-year follow-up questionnaire, so the primary outcome?
Attempt to make contact with them. Yeah, text or phone, email. I'm guessing in the top of my head, but I'm guessing there'll be like a preferred method of contact that they listed.
Yep. Yeah, so yeah, I guess just attempting to call them. If they've said they prefer email, also trying to phone them is good. And yeah, just we don't like set kind of a specific number of attempts, so it's just however many you guys feel comfortable attempting to contact them. And I think we're happy to collect that data for up to 15 months after randomization. Okay, next slide, please. So just to kind of summarize, so after today you can go away and finalize all your training. So that's completing the training log, which we've popped a link there for, is on the training website as well. And then also completing your delegation log. So for that we use a system called Mango, which we're using at the Bristol Trial Centre for a number of trials. So if you already have an account on there, then it's just a case of adding Lollipop to your account. But if you don't have one, then go ahead and create one. And then on the delegation log, once the PI has created an account, they will sort of issue the final PI approval for each of the staff members as their sort of sign off. Yeah, any questions on that? Yeah, Jessica.
Sorry, it's not an especially interesting question. I completed the training log for all the videos before, and obviously ticked the box saying that we hadn't yet had the SIV. Now that we've had the SIV, do I need to try and log into the original thing and write my details as well, and then also say yes to SIV?
I feel like we could probably find an easier way. What do you think, Chloe?
I'd say either just fill the form in again and just do the SIV because we've got the other stuff, or if you want an email confirmation, we can save the email alongside your training logs.
Gotcha, that sounds reasonable. Thank you.
Cool, thanks. Okay, we'll move on to the next slide. This is just a quick reminder to say that we're registered on the Associate PI scheme, but I think you guys are already aware of that because it sounded like there were a couple of you planning to take part in that, so that's great. Next slide, please. And yes, so we do just run through a checklist at this time, which I have to admit I forgot to open, so I'll just quickly do that. But I'm also aware that we don't have a lot of time left, so okay. Right, hopefully you can see that. So PI, CV and GCP certificate is one that will actually be uploaded onto Mango, so we'll receive that when you register on there. PI protocol agreement, so that's just the signature page within the protocol. I'm not sure if we've had that one yet.
Yeah.
So just
I believe okay. Yeah.
Oh, maybe you have. Okay, sorry.
We do have it. Yes.
Okay, sweet. I'll have a look afterwards. And then training logs. So most of you probably haven't done that one yet, but it sounds like we have a few already. And again, with the delegation log, we've already received the fully executed contract, and that's great, and the R&D approval, so you guys are way ahead. Sounds like it'll just be mainly ticking off those sort of delegation log, training log, ISF checklist, things like that. I'll just take those off as I go. Yeah, and then you've arranged study drug storage for the pharmacy. Have we? I think I arranged the pump to be sent out. Has that been received yet?
Yeah, it's all done and it's been signed off by medical physics. So it's been
Amazing.
pack tested.
Fab, thank you. If anyone needed access to the staging database who hasn't already, or needs like a new link, just pop us an email and we can get that sorted out for you. Just if you wanted to do that as part of your kind of training before you open. And then we'll send this to you afterwards, but there's just a few other things to check, which I'm sure you probably already have in place, like just checking you've got 50 ml syringes that you can use on the pump. If any 50 ml syringe should work. Confirming that intralipid's available in the right areas.
Yeah. We don't need to room up.
To
room up, because
they don't have
to their own pumps. Yeah.
Exactly, standards. Yeah, standards and giving set.
Got BD plastic pack.
Yeah.
Yeah, sorry, just some of the videos refer to Terumo syringes, but it's the intraoperative Alaris pumps take any 50 ml syringes, only the post-operative pumps that need the Terumo.
Or the syringe drive.
Localization details, you have to remind me whether we've
I think that's
done
all
that.
done, Liam.
Okay, fab. Yeah, sorry, it's just because I've been away for a couple of weeks, so I can't remember where we're at. That's great. It sounds like you guys already had a copy of the CRF as well, and yeah, so we'll be in touch again after this with a kind of summary of what's outstanding. Not expecting you to remember that.
Thanks, Leah. I won't share the slides again because the last slide's just our contact details, and we'll send you a copy of the slides anyway, so you have that. So that's all from us today. Did anyone have any questions or anything we didn't cover that you wanted to ask?
Yeah, really quickly actually, translations of PIS and consent form. What do we do in the instance of a patient not speaking English as their first language?
So we have translated documents in Polish and Urdu at the moment.
Okay.
So they're available, and we have an account with Language Line. So to have that sort of conversation, you can ring the Language Line. We've got sort of guidance on how to use that as well. If we're probably going to do some more translations, we're kind of just assessing use of them and most commonly spoken languages. So if during your screening there are any patients that that are ineligible because of a language barrier, if you could, when you're giving us your screening details, if you could note the language, we're kind of keeping track of the most common languages that we're sort of missing patients out on to be considered for our next lot of translated documents.
We could probably say now that it would be Turkish that would be our most.
Okay. We'll note that one down. Thank you.
But we can still approach patients though?
Using language line.
Yeah, using language line. Okay, that's fine.
Yeah.
And if we consent a patient language line or anything on about the interpreter used?
Yeah, I think there's an ID you put on the consent form, isn't it,
Okay.
Leah?
Perfect.
Yeah.
And can I just ask, sorry, just on that note, obviously we have received the information sheet and invitation letter and consent form for Urdu and Polish, but is there actual questionnaires for their follow-ups that are in Urdu or Polish?
So we kind of have done this in a two-stage approach because because there's the first follow-up is at 3 months. We're asking, so if you do use the translated documents, to let us know, and at that point, because we're in a bit of a discussion about how best, whether we do paper translated questionnaires or whether again we do phone calls via language line. So once we know the documents are sort of in use, we would then sort of cost up the best approach and sort of speak to our patient advisory group and things like that. So once if you could let us know, we back also do that, and then we'll sort of advise on how follow-ups will be completed.
Thank you.
Any other questions?
Can I say if anyone else has any questions? Just thanks everyone for coming. Special thanks to Jessica that's attended, even though she's doing a night tonight. So yes, nice one, Jess. Yeah, and just to the central team, thanks very much for your time. Mark, lovely to see you again. Hope all well, families well, and I did quite a few site inspection visits, but you know, yours was really thorough, very well organized, and very well attended. So thank you for that. Really appreciate it.
Thank you. That's great feedback. We've trialing sort of a new method with the videos and a more interactive session. So you're not the first site to sort of like that approach. So we'll take that forward. Thank you. So yeah, thank you all for your time as well. I guess my last question is thinking about green light. Have you got any idea when we might be looking at for green light at all?
We've mentioned CMC, so it's up to you now, I guess.
Okay, so yes, after this we'll send through the SIV report and any outstanding actions. Once they've been enough, we can be good to go. I'll organise your IMP SIV as well. So in the first instance, we just send one box of 10 vials, and then once we know how sort of well your recruitment's going, well then the second shipment is likely to be sort of a bit larger. So yeah, if there's nothing else, thank you all for your time, and we look forward to opening you very soon.
Thank you.
Thanks everyone.
Thank you.
Bye.
Good to see you all. Cheers.
Thanks. Bye.